Welcome to the deep dive. Today, we're taking a shortcut to getting well informed on something that, well, affects a lot of us, but can feel a bit complex. Gastrointestinal disorders and conditions of the biliary system. We've got some great sources here covering everything from inflammatory gut conditions to gallbladder health.
That's right. And our goal today is really to unpack these, sometimes complicated topics. We'll look at common things like appendicitis, gastroenteritis,
Right.
and then more chronic conditions like ulcerative colitis and Crohn's disease. And we'll finish up with the gallbladder.
Oh,
We'll pull out the key information so you can understand not just what they are, but why they matter, how they show up, and importantly, what makes them different.
okay. Sounds good. Let's jump right in. We're starting with some acute infections, things that really need immediate attention. First up, peritonitis.
Yeah.
This isn't just a minor stomach ache, is it? What exactly is peritonitis? How does it get so dangerous?
Right. What's really critical about peritonitis is how quickly it can escalate. It's a severe inflammation and infection of the peritoneum. That's the lining, the delicate lining
Huh.
of your entire abdominal cavity.
Okay.
And it becomes life-threatening because when bacteria contaminate that space, maybe from a burst appendix or diverticulum, even a peptic ulcer,
Uh-huh.
it triggers this massive inflammatory response.
Uh.
Delaying treatment, even by hours, can drastically increase the risk.
So given that urgency, what are the absolute red flags, the signs you really need to watch out for?
Yeah, that's a really important question. What cues should make you think, okay, this is serious?
Mm-hmm.
Beyond just general abdominal pain or maybe a low-grade fever.
Mm-hmm.
The cardinal sign, the really distinctive one, is often described as a rigid, board-like abdomen.
Board-like.
Yes, imagine the stomach muscles tightening up involuntarily, becoming really hard. That's an emergency signal.
Wow.
And diagnostically, doctors will look for things like a really high white blood cell count showing that massive infection and maybe x-rays showing free air or fluid inside the abdomen, which points towards a perforation.
That board-like abdomen, it sounds incredibly serious. So
Yeah.
once it's identified, what's the immediate plan?
The absolute focus is stabilization as fast as possible. Non-surgically, it's about getting ready for what might come next.
Okay.
So keeping the patient NPO nothing by mouth, often putting in a nasogastric tube, that's a small tube through the nose to the stomach for gastric decompression, basically clearing things out.
Gotcha.
Then broad-spectrum antibiotics right away, oxygen support, and positioning the patient in what's called semi-Fowler, sort of sitting upright, which helps breathing and drainage.
Right.
But often the core treatment is surgery, an exploratory laparotomy to find and fix the leak or perforation, then washing out the whole area with antibiotics. The goal is rapid pain control, managing fluids, and fighting that infection hard.
Okay. From that widespread emergency to something more localized but still acute, let's talk appendicitis. Most people have heard of it. What's actually happening when the appendix flares up?
So appendicitis is basically an acute inflammation of the appendix, that little finger-shaped pouch that comes off your large intestine.
Yeah.
It can hit anyone, but it's most common in, say, teens and young adults, maybe 15 to 19.
Okay.
And the inflammation usually starts because of a blockage. Often it's these things called fecalis, basically, really hard bits of stool or sometimes swollen tissue. This blockage cuts off blood flow, which leads to infection and that very characteristic pain.
And the pain, where does it typically hit? Is there a specific sequence or cue that helps distinguish it?
Yes, and this is where it gets really interesting for recognizing the cues, because the sequence often matters.
Ah.
The pain frequently starts as kind of a dull ache, maybe cramping around the belly button or higher up in the abdomen. Nausea or maybe some vomiting often follows. Then, as it gets worse, the pain usually shifts and becomes much sharper, more localized, down on the lower right side of the abdomen.
Right.
A classic sign is rebound tenderness at McBurney's point. That's a spot about a third of the way from your right hip bone towards your navel.
Okay, McBurney's point.
Right. If you press there and then release quickly, the pain flares up sharply. That's rebound tenderness.
Gotcha.
Also, pain getting worse with coughing or moving, or maybe feeling better if you bend your right hip. Those can be telling signs too. And of course, labs showing high white blood cells and imaging like ultrasound or CT confirms it.
So once it's identified, sounds like immediate action is needed.
Definitely. It really can't wait. Most patients need hospitalization and surgery and appendectomy to remove that inflamed appendix.
Right.
It's often an emergency surgery to stop it from rupturing, which could cause peritonitis. Exactly. Nowadays, it's very often done laparoscopically with small incisions. That means a much faster recovery. Usually back to normal activities in a week or two, compared to maybe 4 to 6 weeks for the older open surgery.
Much better.
Yeah. And before surgery, it's NPO again, IV fluids, positioning for comfort. And, critically important, no laxatives, no enemas, no heat pads on the belly if you suspect appendicitis. That can increase the rupture risk.
Good to know. Okay, moving from specific organs to something more general but super common, gastroenteritis, what many of us call stomach flu. What's the basic mechanism behind this one?
Gastroenteritis is essentially inflammation of the mucous membranes lining the stomach and the intestines. That's what causes the, familiar diarrhea and/or vomiting.
Yeah.
Usually it's the small bowel that's most affected, often viral, can be bacterial sometimes, and typically it runs its course. It's self-limiting cause, usually ingesting contaminated food or water, often through what we call the fecal-oral route, which really just highlights how important hygiene is.
So prevention is absolutely key here, isn't it?
Exactly. Health promotion, prevention, they're critical. We're talking about really good hand washing, sanitizing surfaces, safe food handling, and storage.
Right.
Because the biggest immediate danger with bad gastroenteritis, especially for kids or older adults, isn't just the misery, it's dehydration. That can be serious.
Okay. So besides the obvious symptoms, what should we look for? And how do we manage it and stop it from spreading?
Well, you want to ask about recent travel or maybe what someone ate recently. New restaurant, street food, sushi. Beyond the nausea, vomiting, cramping.
Yeah.
The main focus is replacing lost fluids. So encourage oral fluids, small frequent sips of clear liquids, maybe electrolyte drinks.
Okay.
If dehydration is bad, IV fluids might be needed. And generally, unless a specific bacterial cause is found through stool tests, you want to avoid drugs that stop diarrhea. The body's trying to flush out the butt.
Right, let it do its thing.
Exactly. And for prevention, hygiene, hygiene, hygiene. Strict hand washing, don't share utensils or drinks, avoid close contact if someone's sick. It's vital to stop it spreading.
Okay, let's pivot now to some more chronic issues. Things that people often live with long-term. Ulcerative colitis, UC, and Crohn's disease. They often get lumped together, but our sources really emphasize some key differences.
They do. And connecting this to the bigger picture, they're both types of inflammatory bowel disease, IBD. The cause isn't fully known, but where they affect the gut and how deep the inflammation goes, that's where they differ significantly. Think of it like different kinds of battles in the same war zone.
Okay, interesting analogy. Let's start with ulcerative colitis, UC. Where does that typically hit, and what does the inflammation look like?
Okay, so UC usually starts down in the rectum and then spreads upwards continuously along the large intestine. Importantly, it only affects the innermost lining, the mucosa.
Just the lining.
Just the lining.
Yeah.
During a flare-up, that lining gets very red, swollen, and can develop these little ulcers that bleed easily. It's a widespread chronic inflammation of that top layer.
And what would someone with UC typically experience? What are the symptoms?
The hallmarks are frequent diarrhea, often many times a day, maybe 10, even 20 liquid stools, and usually with blood.
Wow.
Plus, there's often lower abdominal cramping, that colicky pain.
Yeah.
You might also see weight loss, fever, maybe signs of anemia from the chronic blood loss.
Right.
Recognizing the cues involves getting a really detailed history. How long has this been going on? Any recent antibiotics? And the psychological side is huge. People have significant anxiety about accidents, about the blood. So understanding its impact on daily life is crucial.
How do doctors usually confirm UC, and what's the management approach?
Diagnosis often involves a colonoscopy, so they can directly see the inflammation in the colon. Blood tests will show signs of inflammation, high white blood cells, maybe elevated CRP or ESR. Management is focused on controlling that inflammation and managing the symptoms. Non-surgically, that means various anti-inflammatory drugs, sometimes immunosuppressants, maybe antibiotics. Nutrition therapy is also key, often reducing animal fats and sugars, increasing fruits and vegetables. Stopping smoking is really important too.
Right.
And the goal now isn't just symptom control, it's aiming for mucosal healing, actually getting that bowel lining repaired, which improves long-term outcomes. If meds don't work, surgery might be needed, like removing the colon, potentially creating an internal pouch, or sometimes a permanent ileostomy.
Okay. Now, in contrast, we have Crohn's disease. What makes it so different from UC?
Yeah, while they're both IBD, Crohn's is,
Oh.
well, it's a different beast altogether.
Yeah.
It's also chronic and inflammatory. But it can affect any part of the GI tract, literally from the mouth to the anus, though it most often hits the end of the small intestine, the terminal ileum.
Any part. Wow.
Any part. And unlike UC's continuous surface-level inflammation, Crohn's features skip lead-ins patches of inflammation mixed with healthy tissue. Crucially, it affects all layers of the bowel wall, going much deeper.
All layers.
Right, transmural inflammation. This leads to a thickened bowel wall, strictures which are narrowings and deep ulcers. It can create this cobblestone appearance inside the bowel. And because it goes so deep, patients are at high risk for fistulas, abnormal tunnels, connecting different parts of the bowel or even connecting the bowel to other organs.
That sounds incredibly complex and potentially widespread. What are the main symptoms and challenges for someone living with Crohn's?
It's often slowly progressive and very unpredictable. Because it can be anywhere and affects all layers, you often see severe diarrhea, but also problems with malabsorption of nutrients, leading to weight loss and anemia. Abdominal pain is common, often a low-grade fever, and fatigue can be really significant. Unlike UC, blood in the stool might be less common, or maybe not present at all. You might also see issues around the anus, like ulcers or fissures. And psychologically, that unpredictability, the chronic nature, it really impacts quality of life. Anxiety and depression are common challenges.
So how is Crohn's typically diagnosed and managed compared to UC?
Diagnosis often relies more heavily on imaging that can see the whole bowel, like X-rays or MRE magnetic resonance interrography, looking for those characteristic strictures, fistulas, or thickened walls.
Okay.
The take-action plan, the treatment, often requires stronger, maybe multiple medications compared to UC. Different types of immunosuppressants, and especially these biological responder modifiers, are used to target the specific inflammatory pathways.
Right.
Nutrition therapy is vital. Avoiding things like caffeine and alcohol is often recommended. Managing fistulas if they develop is a big focus. Nutrition, skincare, preventing infection.
And surgery.
Surgery isn't curative for Crohn's like it can be for UC because it can recur elsewhere. But it's often needed to remove severely diseased sections or to perform a stricturoplasty that's a procedure to widen narrowed areas without removing bowel, which helps preserve gut length.
Okay, we've hit the big two chronic ones. But the GI tract has other issues too. Let's look at diverticular disease, often linked with aging and diet, right?
That's right. Diverticular disease can happen anywhere, but it's most common in the colon, especially the sigmoid colon down on the left side. And it's really a two-part thing.
Okay.
First, there's diverticulosis. That just means having these little pouches, diverticula, that bulge outward through the muscle wall of the gut. Many people have them, especially as they get older, and have absolutely no symptoms.
So just having the pouches isn't necessarily a problem.
Exactly. But when those pouches get inflamed or infected, that's called diverticulitis, and that does cause problems.
Right. So what are the signs of diverticulitis?
With diverticulitis, you get symptoms. Typically abdominal pain, specifically localized to the lower left quadrant, often with nausea, vomiting, maybe fever, chills, a fast heart rate.
Okay. And how do doctors usually figure this out and manage it?
Well, for simple diverticulosis, you might not need any tests. But if diverticulitis is suspected, blood tests usually show a high white blood cell count, indicating infection. Imaging, like a CT scan, is often used for diagnosis, though a colonoscopy is usually avoided during an acute flare-up because of perforation risk.
Makes sense.
Management starts with resting the bowel, often NPO initially during an acute attack, then slowly progressing the diet, low fiber first, then high fiber once things calm down.
Okay.
Antibiotics are key for the infection, plus pain relief. And it's really important to know that if one of these inflamed pouches ruptures, it can cause peritonitis.
Again.
Yes, or other serious issues, potentially needing emergency surgery like a colon resection.
Right. Okay, next up, celiac disease. This one seems to be getting a lot more awareness, especially around diet.
It definitely is. Celiac disease is fascinating. It's a chronic autoimmune condition affecting the bowel. Essentially, when someone with celiac eats gluten, the protein in wheat, barley, rye, their immune system mistakenly attacks the lining of their own small intestine.
So the immune system is the problem.
Exactly. This chronic inflammation damages and flattens the lining, which interferes with nutrient absorption, leading to all sorts of digestive problems. And it's often linked with other autoimmune conditions too, like type 1 diabetes or rheumatoid arthritis.
What are the typical symptoms someone might notice?
It can vary a lot, but classic symptoms include things like chronic diarrhea or even constipation, abdominal pain, significant bloating or distension. Also, steatorrhea, those fatty, foul-smelling stools due to poor fat absorption.
Okay.
Weight loss, sometimes anorexia. Diagnosis usually starts with blood tests looking for specific antibodies, followed by an endoscopy to actually look at the intestinal lining and take biopsies.
And the treatment.
The absolute key takeaway, the only effective treatment we have right now to achieve remission and let that intestine heal, is a strict, lifelong gluten-free diet. No exceptions.
Lifelong commitment. Got it.
Okay.
Okay, finally in this section, let's briefly touch on parasitic infections affecting the GI tract.
Right. These are typically caused by microscopic parasites getting into the body, usually through contaminated food or water, that oral fecal route again, or sometimes through specific sexual practices.
Okay.
Common ones you might hear about are things like giardiasis, amoebiasis, cryptosporidium. Diagnosis is usually made by examining stool samples under a microscope.
What are the signs, and what's the #1 prevention strategy?
Well, in terms of cues, a history of recent travel is often a big clue, especially to areas with iffy sanitation. Symptoms often include persistent, frequent, liquidy, maybe foul-smelling stools, sometimes mucus or blood, maybe a high fever, general abdominal tenderness, vomiting. And for prevention, the absolute key, the most impactful thing, is meticulous hand washing, both for the person who's infected and everyone around them, to stop the spread.
Hand washing, always crucial.
Absolutely. Treatment involves specific anti-parasitic drugs, like metronidazole for some types, plus making sure the person stays hydrated, maybe with IV fluids if needed, and finishing the entire course of medication is really important.
Okay, great overview of intestinal issues. Now, let's shift gears slightly and talk about the biliary system, specifically the gallbladder.
Right.
This little organ, tucked under the liver, stores bile. What kind of problems does it run into?
The main issues really boil down to two things. Inflammation, which is called cholecystitis, and the presence of stones, cholelithiasis.
Okay.
Cholecystitis can happen with stones, that's calculus cholecystitis, or sometimes without stones, acalculus, and it can be acute, sudden inflammation, or chronic long-term irritation.
And cholelithiasis is just having gallstones.
Exactly, just the formation of gallstones. The problems really start when these stones cause a blockage, maybe in the cystic duct coming out of the gallbladder,
Right.
or the common bile duct that drains bile from the liver and gallbladder to the intestine.
So the stones are often the root cause. How do they actually form?
Well, the exact mechanism isn't perfectly clear, but it seems to involve a couple of things. Abnormal metabolism of cholesterol and bile salts seems to play a big role. And also, if the gallbladder isn't emptying properly, what we call impaired motility, that can contribute. The stones themselves are usually made up of cholesterol, bilirubin, which is a bile pigment, bile salts, calcium, various proteins. They get classified as cholesterol stones, pigmented stones, or mixed.
Okay. And what makes someone more likely to develop these stones? I feel like I've heard a mnemonic for this.
Yes. This raises an important point for you to consider. There is a classic mnemonic, often used especially in medical training, the 4 Fs.
Ah, yes.
Female, 40, meaning around age 40 or older. Fat, referring to obesity. And fertile, meaning having had multiple pregnancies.
Right, the 4 Fs.
Exactly.
Yeah.
Now, those are common associations, but there are other risk factors too, like a family history, eating a diet very high in cholesterol, a sedentary lifestyle, having type 2 diabetes, rapid weight loss, like after gastric bypass, can trigger them. Even certain hormone therapies like HRT or birth control pills can increase risks slightly.
Got it. So given those risks, how would we recognize if someone might have cholecystitis, that gallbladder inflammation?
You'd want to ask about their diet, especially if fatty foods seem to trigger symptoms like indigestion, gas, nausea, vomiting, or abdominal pain.
Okay.
The absolute classic sign of acute cholecystitis is pain in the right upper quadrant, the RUQ of the abdomen.
RUQ pain.
Yes. And importantly, that pain often radiates.
Yeah.
It might go to the right shoulder or even around to the back near the right shoulder blade.
Interesting radiation pattern.
Very typical.
Yeah.
And a key physical exam finding is Murphy's sign. If a doctor presses on that RUQ area while the person takes a deep breath in, the pain gets suddenly worse, making them stop inhaling.
Murphy's sign. Okay.
Sometimes Bloomberg's sign, that rebound tenderness we talked about with appendicitis, can also be present over the gallbladder area.
Right.
Now, with chronic cholecystitis, the symptoms might be milder, more gradual. People might ignore it until later signs appear, like jaundice, yellowing skinnies, clay-colored stools, or dark urine, which suggest a blockage is interfering with bile flow.
Okay. What about actually diagnosing it? What tests are used?
Blood tests are usually done. You'll often see a high white blood cell count because of the inflammation. Liver enzymes, things like alkaline phosphatase, AST, LDH might be elevated. Serum bilirubin can be up too, especially if there's blockage. And if the pancreas gets involved, which can happen if a stone blocks the shared duct, then amylase and lipase levels will go up too.
Okay.
Now for imaging, an abdominal x-ray might show some stones, but the ultrasound of the RUQ is usually the best initial test. It's really good at seeing gallstones and checking for swelling or thickening of the gallbladder wall in acute cases.
Ultrasound first.
Typically, yes.
Oh.
Other tests like HID scans, which look at gallbladder function, or ERCP or MRCP, which visualize the bile ducts, might be used if obstruction is suspected or the diagnosis isn't clear.
So once cholecystitis is suspected or confirmed, what are the options? Is surgery always the go-to?
Managing the acute pain is always the first priority. Non-surgically, treatment involves avoiding fatty foods, maybe resting the gut completely, NPO if there's lots of nausea and vomiting, IV fluids for hydration, pain meds like opioids or sometimes strong NSAIDs like ketorolac, antiemetics for the nausea. In some specific cases, there are medications, oral bile acids, that can sometimes dissolve small cholesterol stones over time.
Okay.
And there are other non-surgical options for specific situations, like draining the gallbladder with a catheter if surgery is too risky, or maybe ESWL, that's extracorporeal shockwave lithotripsy, using shockwaves to break up stones. But that's less common now.
So often surgery is the main solution.
Yes, very often. Cholecystectomy, surgically removing the gallbladder, is extremely common. It's one of the most frequent abdominal surgeries done.
And how is it usually performed?
Mostly laparoscopically now. The lap col.
Lap col, right?
It's minimally invasive. Just a few small cuts using a camera and special instruments. This means fewer complications, much less pain after surgery, and a way quicker recovery. People are often back to normal activities within about a week.
That's impressive.
It really is. Post-op care focuses on monitoring those small incision sites, managing pain, encouraging walking early on that helps with the gas they use during surgery, and promoting a sensible diet, usually low-fat, high-fiber initially.
And the traditional open surgery?
Much less common, usually reserved for really severe inflammation complications or if the view is poor laparoscopically. It involves a larger incision and a longer recovery time.
Okay.
One important thing to mention. Sometimes after surgery, people can develop symptoms again, pain, vomiting, diarrhea. It's called post-cholecystectomy syndrome. So if that happens, it's important to report it as it needs checking out.
Good point. Wow, we really have covered a huge range of conditions today. From those sudden emergencies like peritonitis and appendicitis, all the way to managing chronic diseases like UC and Crohn's, plus gallstones, parasites, and it's quite a landscape.
It really is.
Yeah.
And this deep dive, I think, really highlights how different these conditions are, even though they're all within the same general system. Understanding their specific symptoms, the underlying issues, the right management, it's so crucial.
Yeah.
You've definitely gained a solid overview now, cutting through some of the noise to get the key knowledge.
Absolutely. And as you, our listener, reflect on all this information, here's maybe a final thought to consider. How might really understanding the specific pathways of pain or inflammation we talked about, think about that rigid abdomen in peritonitis, or the precise location of McBurney's point in appendicitis, or how gallstone pain radiates? How might understanding those specific signals not just help doctors with diagnosis, but maybe fundamentally change how we listen to, perceive, and respond to our own body's signals, whether they're subtle or screaming?